Thanks, Dr. Mann. Pleasure to be here, and really appreciate the invitation to be at this really fascinating meeting. I have about 7 minutes to address whether the absolute blood pressure management targets should really guide our management in this situation. Now, we all know that the relationship between blood pressure and outcome in this setting is likely linear or in some fashion related, and that there's no magic number at about 90 millimeters where everything changes. And we can well understand that the reason why we use a number, despite all the critiques of using an absolute number to enroll in clinical trials, was simply because we wanted a homogeneous group of patients to get into the study. But in clinical practice, using an absolute number would usually let us down. I think what Marwan has challenged me with here is not enrolling patients into a study, but once you do get a patient into the study, does achieving a blood pressure target actually lead to successful outcomes or better outcomes? And I'll try to answer that question. This is Bill Gates. I share his concern. I don't know the answer to this question, but I hope it's I don't know yet, and there's some smart folks in the room who know the answer. But what I will do in the next 4 or 5 minutes is go through what I think the data shows at this point of time. I think it's a really important question, because if there is a target, and if we're going to treat our patients towards the target, then as mentioned by all the speakers, we have only 2 ways to go. Either we use therapies like vasopressors and inotropes, and we know the side effects of these, including increased automaticity, increased arrhythmias, increased vasodilatation or vasoconstriction, and most important in an acute ischemic situation, increased ischemia. Or we use devices, and those come with the consequences of having vascular access, vasodilatation from SIRS, and other issues. So I think trying to get at this answer is a really important one. So what do we know from the literature? The sepsis folks have always used a target. Ever since the survival with sepsis guidelines, they've used a blood mean arterial pressure of about 65 millimeters of mercury. When you look at that data, there is certainly some stuff in the basic lab that supports it, but the clinical evidence is quite soft. This is the best trial done in the New England Journal of Medicine by folks in France, around 6,000 patients with sepsis, targeting 2 blood pressures, a mean of about 65 to 70 versus one of 80 to 85. And you can see the treatment was really good in that it separated the control and trial arms to try to understand the question being asked. But when you can see the event and the outcomes really made no impact in the setting of florid sepsis as to whether this was a target or not in that setting. This is a neurological outcomes post-cardiac arrest, and I think this area is a little more interesting because, as you can see on the left, in most of us, under normal conditions, the cerebral autoregulation is pretty profound and pretty consistent over large areas of mean arterial blood pressure. But in the post-arrest situation, that window for cerebral autoregulation is really narrowed down. And so you might say that this is one area where you might want to target a blood pressure because it comes with a little more elegant pathophysiology. But even there, I will concede, as seen in the bottom, when you divide people post-cardiac arrest into tertiles of systolic blood pressure and then further into the tertiles of vasopressors required to get them there, there's really no change in outcome, once again suggesting that while it's an attractive metric, it may not really lead to successful outcomes. Let's turn our attention to cardiac trials in shock. This is a TRIUMPH study that we did to try to prove the vasodilator hypothesis using tilarginine acetate, an inhibitor of nitric oxide inhibition. And what I do want to make a case for here is that blood pressure is important. When you look at the predictors of outcome in this population, you can clearly see that the systolic blood pressure has a profound impact on predicting risk. This is the shock trial data done by Lynn Sleeper, and you can once again see that, yeah, the lower your mean arterial blood pressure, the more points accumulate for your poor outcomes. But what I do want to pay attention to is that when you compare hypoperfusion, a marker of tissue hypoperfusion, to blood pressure, and let's talk about a blood pressure of 60 to 65 versus 66 to 70, that little difference in mean arterial pressure seems to make very little outcome changes as compared to something as marked as the presence of hypoperfusion. And I think that's reflected in a more current kind of registry like the IABP2 shock predictor. We've discussed that often, and we all saw that in the IABP shock predictors, blood pressure does not figure, because when everyone is down and in the dumps, then a systolic blood pressure or a mean of 40 versus a mean of 45 really doesn't make a difference. You're in trouble. And so when you really look at that and you put that in a context of having some other tissue perfusion issue like an arterial lactate or some other measure, blood pressure usually falls out. So I think my goal is to try to prevent tissue hypoperfusion and monitor that the best as I can as my reasonable target. The most important question to ask, in my opinion, is not what's the blood pressure, is why is there hypotension? If it's because of the intravascular status, and that's the simplest thing to do, like in an RV infarction, you give volume. If it's an acute blood loss anemia, you give blood. Those are simple ones. If it's an ineffective stroke volume, increasing blood pressure by itself is not the answer, right? An ineffective stroke volume because of LV outflow tract obstruction, if you end up giving a vasopressor in that situation, you're going to worsen the situation. If it's because of severe MR and a flail leaflet, and you just want to increase the blood pressure to combat an ineffective stroke volume, that's also not what you're going to get. So I think it's really important to understand and treat mechanistically the ineffective stroke volume by effective pharmacological intervention and temporary mechanical support. I think the one thing that we underappreciate in the CCU is how many of patients of ours are chronotropically incompetent, either because they've been pharmacotherapeutically paralyzed by, let's say, a beta blocker, or because their pacemaker is set at a fixed rate of 70, and now they're having a large anterior wall infarction, and all you do is increase the heart rate, and that cardiac output increases quite profoundly. And finally, I think the most challenging issue is if it's peripheral vasodilatation and a SIRS-like state in the setting of an acute myocardial infarction, this is clearly an area where we need to do more work. And so all I think we should do is, rather than use a blood pressure target, we need to trend the data and look at broad parameters of patient outcome, whether that be clinical, from vitals to mentation, to urinary output, to peripheral pulses, to capillary filling time, whether we're looking at biochemical parameters like the clearance of lactate or the mixed venous oxygen, whether it's hemodynamics and the reduction in vasopressor requirement. But I think at the end of the day, the only thing that salvages your patient is, has the primary issue been resolved? And if that primary issue has not been resolved, then just treating the blood pressure, no matter what your target, is going to lead you down a rabbit hole. Thank you.
Questions?
It's a great talk, thank you. I think for me, where this question's most interesting is in the ECMO-supported patient, where you can have tremendous blood flow, but there's a vasodilatory shock state. And I find myself arguing with the intensivists who are up-titrating Levophed to try to maintain a MAP of 60. And I don't know if that's good or not good, but I think it's probably not good. So what do you think is the lowest MAP we can tolerate, provided you can, you have infinite amount of flow to provide? Where do you think that cutoff is where you really have to be at least there?
I come in sharing your bias, and so I try to be neutral to what the blood pressure is. But I do see at some point of time the mean arterial blood pressure is going to let you down. I don't think it's 65 and 70. I think I'm much more permissive, and I probably stick to something like a 60 without having any data to back me up. But I think as long as I see a urine output and I see peripheral parameters that meet my requirement, regardless of what the blood pressure is, I tend to remain as unresponsive to it as possible, because I think the collateral damage from vasopressor use and other agents is not to be underestimated. But do I have a right answer? I don't.
50? Would you allow 50?
If the guy were talking to me,
do we hear 45? Going once, going twice.
No, let's say, the heart failure
Your
folks are
slide
here.
showed 50 for auto-regulation of the cerebral circulation. 50 was where it cut off. So where does 60 come from? Why are we always after 60?
Well, I just think in the setting of an acute infarct or something like
They're
that.
already in renal failure at that point because they're on so much levofed to maintain the map that kidneys have already shut down. So I'm not sure what the benefit is of trying to stay there.
Yeah. My biases are more in the folks who have long-standing heart failure. They've lived on the wards with blood pressures of 80 all their life, and then you come on and they get cemented by some rapid response team, and the mean arterial pressure is 50, and then suddenly they're escalating it. That can't be good. I do think that in someone who is otherwise normotensive and just gets hit by a big infarct or something out of the blue, having something like 60 is probably a reasonable target. I do think that an acute on chronic injury is a little different from an acute injury, and trying to differentiate that is probably helpful.
I have a question about, back here, I have a question about, so when you have an intra-aortic balloon pump in place, what pressure and what parameters do you follow to titrate pressors? Which of the pressures do you use, and how you titrate the pressors?
So I normally look at the augmented blood pressure and see what the response is to that. And if the person's augmenting well, then I'm pretty happy with that. And I get a 10 millimeter response to an intra-aortic balloon pump. I would take that as a positive response, and I get a nice augmentation curve. I'm pretty happy with that.
I'll give you a scenario. There is a guy who's intubated on CRRT. He's got acute renal failure. He's on ECMO. His mean pressure is 55. You don't know his mental status. It's a bridge to decision. At what blood pressure you'll be comfortable? Would you let him drift down to 55 and 50, thinking that he'll have more cerebral damage, versus try to keep him at 60 or 65? Or how do you get to that number? Because you don't know him from before he was living at 80 or 120.
Correct. I don't know where we are in that 55, 60, 65 range. I know you don't want to go 70, 70. It's like super oxygenation and all of those other things. All you have in that patient is other surrogates of other organ beds. Do we treat the brain uniquely in that situation? I think that's a challenge. I have no, apart from just using my bedside gestalt, I really don't have any magic bullet for that.
We can debate about it. Bottom line is flow and resistance, end organ. So nobody knows exactly what exactly is the perfusion pressure needed for the microcirculation and what's the flow needed. Flow, we can put 60 mils per kg or 70 mils per kg and we can come up with a number. But for resistance, exactly we don't know. And each organ is different. Brain is different from kidney, is different from liver. So we can salvage the vital organs and say this is what we're looking for. So everybody's encountered in their practice that we put in an ECMO and a vasodilatory shock and we can't float 9 liters and 10 liters and the microcirculation goes away. But my question is this: if the experts in the field, especially transplant, the current allocation, they're putting blood pressure as one of the criteria, even though we have sworn evidence of cardiac index less than 2 and a wedge pressure more than 18, they still want a systolic blood pressure of less than 90, and you know that you already established these patients have a low cardiac index and they have a higher wedge on support. So that's very curious for me, because if you've already established microcirculation problems based on hemodynamics, why do you need the blood pressure to be below 90?
Correct. But I'm more concerned about the other area. I think, when you talk about folks who get referred to quaternary centers that have the ability to do advanced support, I think a lot of people are undertreated, but a lot of people are overtreated too, just responding to a number called a blood pressure without understanding or paying attention to the mechanism. And I think the key here is understanding the mechanism. I think you can have whatever support you want, but unless you know I think that when you do that transfer, like we spoke about, not only do you want to know a sky stage, you want to know, is this an RV problem, is it an LV problem, is this a biventricular problem, and is this a problem of the myocardium, is this a problem of the valve, is this a problem of the pericardium? I mean, it's strange how every week you see a right coronary open 7 days out with a big whopping ventricular septal rupture who's just got 2 plavics and everything else, and we still are just going after the blood pressure and not understanding that ultimately, to get the patient well, we need to know where the fortress was breached, and I just don't think we pay enough attention to that.
Questions from the panel? Well, I just have a comment. I think by itself, blood pressure is an imperfect measure. You don't even know when they are measuring the blood pressure. How many times you come and you see the nurses putting the cutoff here, or if the arterial line is in the right, in the radial artery, or is in the femoral artery, or you are getting central blood pressure or peripheral blood pressure, you know? So I think as everything, we can never rely on just one parameter, especially if that parameter is not perfect.
Yeah. And you know, I think it's an important thing, because I've certainly reviewed papers where a lot of people treat ischemia just like a stroke person would treat a penumbra of infarct, and think that by increasing pressure, we're having an increased penumbra in the margins of this infarct and decreasing size. And there's been elegant studies of troponin release at different mean arterial pressures showing, you know, that it may be a target. I just think it's a little crude at this point of time to be a parameter to gauge our success in intervention.
This is a great discussion. You know, I think we all would agree that you know, saying there's a single blood pressure target for all patients is absurd. You know, a lot of the data is sort of arbitrary based on, you know, physiologic studies. There's a nice recent study in patients with vasodilatory shock showing that if, you know, older patients above age 65, where there's some vascular stiffening and low diastolics, they actually do just as well or better at a lower MAP closer to 60. And I think that probably a lot of our patients, it's the same thing. But I think the point that you made about focus on the end organ function first, then figure out, you know, what the blood pressure should be, I think that's a very important point.
It's interesting that, Jacob, you said that about, I didn't know about that study. I was just thinking about David's question. So what we're missing in our field, at least in our field where, unlike sepsis, you have a septic waveform with plenty of pulse pressure, is the pulse pressure. It'd be nice to know how much pulse pressure impacts outcome at any given mean. And the reason I say that is because if you look at your cerebral autoregulation, we know that you're basically autoregulating normally with a pulse pressure. And this is why German teams like the Novolong team, I don't know if they're here in the back there, they're developing, they have an iCore machine that has pulsatile ECMO. And they need to know how much to dial that so that you can have what could be benefits to human physiology. And I just want to ask our panel and colleagues, I mean, does anybody look at the pulse pressure? I for one, look at the pulse pressure sometimes the day after an LVAD gets put in, and I see our nurses, for example, bringing down the blood pressure because they're worried about bleeding, and the RV's gone. And then the pulse pressure's narrowed, and then we're going on high-dose pressors, really high dose. So I wonder if, you know, I don't know if Dan Burkhoff is here, that surplus hemodynamic energy of a pulse pressure means a lot for the organs, and we just haven't measured it in cardiogenic shock. But I don't know if there's a benefit to it. That's just what I want to ask.
Thanks very much. We'll move on to the next talk.